Usha. She is a professor of obstetrics and gynecology in Ramchandra Medical College, and she's going to talk about management of pregnancy-associated hypertension, the changing concepts in the management of hypertension in pregnancy. What we learned 25 years back no longer holds true. A lot of things have changed. I think it would be very interesting to hear from an obstetrician about management of hypertension in pregnancy. Over to Dr. Usha.
Good evening. I first wish to thank Usha HT for my being here this evening, and I would really place on record my appreciation because all our batches we just meet and have fun. But when you're combining academics and fun, it's really truly different. And it's the first time I'm going to be talking on preeclampsia to a non-obstetric population. So I tried to make it as simple as possible. Hypertension and pregnancy, primarily we see preeclampsia, most commonly in this part of the world. And we know it's important because it's one of the leading causes of maternal and perinatal morbidity and mortality. When there's less than optimal care to these women who have preeclampsia, we know that we lose mothers to this day. 10 to 20% rising incidence. When we studied in RSRM many years ago, we used to see preeclampsia and then we attributed that to girls getting pregnant at a very young age, adolescent girls getting pregnant. Then it was called teenage pregnancy, we now call it as adolescent pregnancy. But the picture hasn't changed. 3 decades, 2.5 decades later, we find the same number of preeclampsia now. And primarily we find that the age of marriage has probably risen up in most places, at least in the urban areas. But like Dr. Jaishankar said, obesity has now compensated for that. So obesity is contributing to preeclampsia in pregnant women. Women at the pre-pregnancy weight start off with only 65 to 70 kgs many times, and they all invariably land up with preeclampsia. Next slide. I just put in a few slides. 30-year-old primigravida, repetitive recording of blood pressure of 150/100, 34 weeks of pregnancy with absolutely no proteinuria. What do you think this condition is likely to be? I don't want to be asking you this question, but any guesses?
What was the blood pressure before 20 weeks?
This is the first time that we are recording her blood pressure to be 150/100.
The blood pressure was normal before 20 weeks.
You need to assume that it has been normal.
Okay, then you call it as gestation.
Repeat that. We can check the BP again.
Yeah, we have repeated. That's why I said repetitive recording of blood pressure is remaining to be 150/100.
So, okay, you call it as gestational hypertension.
Yeah.
And now the definition of preeclampsia has changed. If even without proteinuria, you can still label them as preeclampsia if they have associated end organ symptoms.
Yeah, but still by definition, multi-system disorder, preeclampsia needs to have some proteinuria. So this is gestational hypertension. I just put in this slide because we don't use the terminology PIH any longer, which we used to be talking earlier. So this is gestational hypertension, which is just rise in blood pressure beyond 20 weeks with no proteinuria. 19-year-old primigravida, 35 weeks of gestation, mild facial edema, urine albumin of 2+ with a blood pressure of 140/100. It's obviously staring at our face. This is a patient who has preeclampsia. Now, like Dr. Bala said, edema is no longer included in the definition of preeclampsia. It used to be a triad: high blood pressure, proteinuria, edema. Edema may be there, may not be there. She can still be a preeclampsia. Proteinuria most often is there. 10 to 15% of patients with no proteinuria, with no obvious rise in blood pressure, can still go on to develop imminent eclampsia or eclampsia. This is one point that we keep driving to our postgraduates also, because don't think that they will all land up with only a high blood pressure to go on to develop seizures or eclampsia. Next slide. 34-year-old primigravida, 16 weeks of pregnancy with a blood pressure of 150, 102 with no proteinuria. Whenever we find blood pressure which is high in a woman prior to 20 weeks of pregnancy, we know that it is a pre-existing hypertension. She is a chronic hypertensive with pregnancy. Subsequently, when she develops proteinuria around 33 weeks, we call that as pre-eclampsia superimposed on chronic hypertension. So these are the four types. You have gestational hypertension, we have pre-eclampsia, we have chronic hypertension in pregnancy, and we have pre-eclampsia that gets superimposed on chronic hypertension. And we keep talking of 33. If you see all my slides, I have put that only as 33 weeks and 34 weeks, because clinically these women develop high blood pressure only around that period, though the pathology happens much earlier, around 20 weeks. So these are the various risk factors that are associated. We don't know the cause of preeclampsia. So we know that these are certain conditions that can get associated with preeclampsia. Primigravida, previous history of preeclampsia is a very, very important factor that can contribute to preeclampsia in the current pregnancy. Any thrombophilic disorder, multifetal pregnancy, IVF pregnancies, assisted reproductive technique for some reason have been associated with a higher incidence of preeclampsia. Diabetes mellitus, obesity, extremes of age, very young, less than 20 years, beyond 35 years. Next. So this is a very, very important thing that I always wish to drive in. We cannot prevent preeclampsia. A lot of times patients will come, I'm seeing Prabha shaking her head, because the first question they will ask is, this time I lost my pregnancy because of preeclampsia, am I going to be having this again? And can you do something to prevent preeclampsia? We know that preeclampsia is a pregnancy-specific disorder that is based on placental dysfunction. We don't know the exact cause, it's multifactorial. So you cannot prevent preeclampsia. We can only prevent complications of preeclampsia. So the principal goal of managing a preeclampsia is to prevent eclampsia and various other complications that can go associated. So if we had to describe the pathology of preeclampsia in one single word, we would say it is vasospasm. Clinically, it will present only at 34 weeks. To just refresh on the knowledge of a little physiology that happens during the development of the placenta. We know there's something called a second wave of trophoblastic invasion, where you find that the spiral arterioles will marginally increase in their diameter. Now this will bring down the blood pressure during mid-pregnancy. Now as the blood volume increases, the blood pressure reaches normal in the third trimester. So though the pathology of vasospasm in a preeclampsia occurs much before around 20 weeks, for it to clinically present in a woman, it will happen only during somewhere around 34 weeks. So clinically you will find high blood pressure in preeclampsia only around 34 weeks. If you find a pregnant woman having preeclampsia earlier than 32 weeks, we still call preeclampsia, but we prefix the word early onset preeclampsia, because it's unlikely to find preeclampsia so early. So less than 32 weeks, if she has preeclampsia, it's early onset. And when they have early onset preeclampsia, it's very important for us to rule out one condition, and that is antiphospholipid antibody syndrome. It's important to rule out in these women. Some of the myths of preeclampsia, to this day, we just need to tell them that they will start eating salt-free diet and get cramps, which is very common in pregnancy. So there's no need to restrict salt. They don't have to eat plenty of salt, like what he said, pickles and various chips and other things, but salt need not be restricted. We need to tell them that preeclampsia has nothing to do with the pathology of chronic hypertension. It's everything to do with the placenta. The moment the placenta is delivered, her blood pressure is going to get back to normal. So there's no need for this. And a lot of times we find, even to this day, these women will have a lot of edema. You'll find their in-laws or the mothers giving them barley water. It acts like a diuretic, and they feel that this edema is going to get lesser. So we need to say that all those is not needed, and complete bed rest is really not needed. It is modified, and whatever she can do, she can continue to be doing. It's not proven to be of any great benefit in reducing the blood pressure. Low dose aspirin, I wish to talk a little about aspirin. Lot of studies, plenty of studies to this date have shown that aspirin in the dose of 60 to 80 milligram per day, starting as soon as we identify the cardiac activity, is being given to this day too. Empirically, a lot of us prescribe aspirin, but only when they have a previous history of preeclampsia, previous history of fetal growth restriction, or previous history of a Doppler having showed changes in the fetal blood flow. It has a small to moderate role. It does not have a very great beneficial role. So we can use, but it's not a wonder drug. So what are the investigations? This is something very commonly taking place in, especially in medical colleges. In our hospital, we will find our PGs will write all the investigations under the sun. The moment her blood pressure is 140/90, you will find PT, PTT, INR will invariably be there in the panel. So last week I said everybody writing one investigation that's not needed is going to drop 10 rupees into the box that I've kept in my room. I've already collected 50 rupees in 2 days because they just keep writing any investigation that just comes to their mind. We don't need to be doing all that. The first thing that we need to know is she throwing proteins in the urine? So urine albumin is very important. Platelet count, because we need to rule out HELLP syndrome. Hemolysis, low platelets, elevated liver enzymes. HELLP is a killer. So we need to identify whether these women have HELLP syndrome. So we do those tests. Serum uric acid, for obvious reasons, it can alter the tubular reabsorption of uric acid, the glomerular endotheliosis, and so we need to know that. Funduscopy, because vasospasm, the only vessel that we can probably find out the severity of preeclampsia is by looking at the fundus. And finally, only in severe type we need to do coagulation profile. At this point of time, I wish to say that a lot of textbooks still say preeclampsia is classified into 3 types: mild, moderate and severe. There is no such classification any longer. It's preeclampsia without severe features, preeclampsia with severe features. There are only 2 types. Next. This is something that we need to tell all patients who have preeclampsia, because the only concern in us is this woman can start throwing convulsions at any point of time. So we want to prevent convulsions, we want to prevent eclampsia. So these are some of the imminent signs that can happen: epigastric pain, vomiting, blurring of vision, headache, oliguria, edema in the non-dependent areas like the face, thrombocytopenia and elevated liver enzymes. These are very important. Just 2 weeks ago, we had a primea gravida who had HELLP syndrome with pulmonary edema in the ICU for almost a week, and her bilirubin was 11. And today she's back for a checkup with a bilirubin of 2.5. So bilirubin is going to take a little longer time, but she was really sick in the ICU with pulmonary edema and HELLP syndrome. And her blood pressure was not very high. Her blood pressure was only 130/90. So HELLP syndrome, 10 to 15% of women with normal blood pressure can still have low platelets and elevated liver enzyme. HELLP syndrome can be very difficult and challenging to diagnose in clinical practice. So what is the principle of management? If the blood pressure, the guidelines will say 170, 110 according to NICE and ACOG, but for Indian standards, we still see women throwing convulsions when they go beyond 160, 100. So anything beyond 160, 100, persistently we need to start antihypertensives. But a lot of obstetricians, we are so stuck in our head. I must admit that the moment we see 130, 90, we will see all of them getting antihypertensives. We really don't need to do that. And we don't have to bring down their blood pressure to 120/80. That's the most dangerous thing to be doing, but that happens all the time in practice. Corticosteroids if less than 34 weeks. We don't need to be giving corticosteroids if they are beyond 34 weeks. And we don't need to keep on repeating corticosteroids more than the 2 doses that we normally give. Betamethasone 12 milligram, intramuscular 2 doses, 24 hours apart, and that's it. We don't have to keep repeating even if her pregnancy continues for more than 2 to 3 weeks. Magnesium sulfate, which is primarily used only for eclampsia, can also be used for severe preeclampsia. Next. So what are the antihypertensives? Gone are those days where we used to be using only alpha methyl dopa, 250 milligrams. Some of them will get 250 milligram BD. Then we used to wonder, what is this drug going to be doing to a pregnant woman? 250 milligram BD. So we need to give an ideal dose. Long half-life and better drugs has put alpha methyl dopa to the background. So the primary first line now is labetalol. And labetalol has an advantage, it is available both as oral as well as intravenous. So if you have a patient for whom she has severe features and you can buy time, you can give her oral. If you have a patient with imminent eclampsia or you have eclampsia, you can put her on intravenous labetalol. So labetalol has become the first line. Hydralazine is now the second line in severe type of preeclampsia because almost all patients, the blood pressure can be controlled with labetalol. Previous slide. Nifedipine, very rarely used now. Previously, they used to give, some of them used to give it even sublingual, never to be given sublingual, only oral. But now since labetalol is being used primarily, nifedipine not so commonly used. Next. So magnesium sulfate can be used in these situations when a woman has uncontrolled high blood pressure in spite of medication, or you find that preeclampsia has come with severe features where you anticipate eclampsia like imminent eclampsia. You need to put her on magnesium sulfate. Next. No diuretics in pregnancy at all. Never administer diuretics. Diuretics need to be given only when we document, when we have evidence of pulmonary edema. Otherwise, these drugs have no place on a routine basis. Imaging very important because we need to remember we have 2 lives. We have the mother and the baby. And because of the placental dysfunction, there's likely to be a fetal growth restriction. So the ideal gold standard of diagnosing is by doing the fetal biometry. The biometry that's very commonly affected is the abdominal circumference of the baby, which is likely to fall. Apart from that, the amniotic fluid index or a single pocket, vertical pocket, is likely to become less, which is called oligohydramnios. And the third point is the weight of the baby that will fall below the 10th percentile. 10th percentile for that population. So these are some of the things that we need to do. So at this point of time I need to say is, a lot of times we do an ultrasound and we write with Doppler. We don't have to do Doppler as a routine at all. We need to do ultrasound for a patient with preeclampsia and see whether the baby is growth restricted or not. And only if the baby is growth restricted, we need to go ahead and do a Doppler because we need to find if the umbilical artery and the middle cerebral artery are showing compensation only when there is a growth restriction, not routinely. Next. So some of the last few slides. So when do we deliver a patient irrespective of the gestational age? There are situations where we tend to overlook the baby and go ahead and deliver the mother. So we always want to make sure we have a good baby and we have a healthy mother at the end of a delivery. But if we are made to make a choice, we need to overlook the baby and deliver her irrespective of the gestational age. When there is uncontrollable severe hypertension, not amenable to medication, eclampsia, there is absolutely no role in control and continuing pregnancy or having an expectant management. When they have complications like pulmonary edema, abruptio placenta or disseminated intravascular coagulation or a non-reassuring fetal status on a non-stress test, we need to deliver her. So simple thing that we make sure that the baby is fine is asking them to do a daily kick count. Now this is done very simple, 3 times a day, 1 hour in the morning, 1 hour in the afternoon and 1 hour at evening. All she needs to do is in that 1 hour, she must be able to appreciate at least 4 times the baby's movements. Now we give her a thread and she starts making one knot in the thread. That's what it's done in the ward. But then when the postgraduates don't tell them how to do it, I find that they just keep on knotting it. Some 50, 100 knots will be there for the whole day. So they don't have to be counting the entire day because that's maddening and they'll go crazy. So just 1 hour, and the moment we tell them 8 to 9 you count movements. If you feel 4 movements by 8:15, stop counting. That's it, your baby is doing well. This very, very important subjective method of finding out whether a baby is doing well or not. Non-stress test, we know it's a recording similar to an ECG, it's a graphical representation. It will tell you that every time she is appreciating a fetal movement, there can be an acceleration in the fetal heart rate. So this is something that we can do twice weekly. Amniotic fluid volume, weekly. All this is beyond 37 weeks. So when do we deliver patients with preeclampsia? If they have no severe features, if she is not having any of the imminent symptoms, we can wait till 40 weeks. Our magic number is 40. If we are made to compromise, then we come down to 37. If we are still made to compromise, we'll come down to 34. Anything less than 34, we are not really very comfortable. So 40, 37 or 34. Lot of babies in most centers, especially in ours, do very well beyond 34 weeks. Even at 32 to 34 weeks, most of our babies do well in good neonatal setups. When they have severe features, there is no way you can go beyond 38 weeks because once your 37 completed weeks are done, your baby is mature enough to be delivered. And there's a big large study done by Arul Kumaran from one of our very famous obstetricians who found that Indian babies mature much, much earlier than most counterparts all over the world. And he compared it saying, students of 17, 18 years join medical college in this part of the world where they take still 2 or 3 years later where they join. So probably in utero itself they mature much, much earlier. So they find that once you cross 37 weeks, you need to deliver her because otherwise you're putting her at a very high risk of developing seizures. And if she has imminent symptoms or she has complications or she develops eclampsia, there's absolutely no question. Just go ahead and deliver her at whatever gestational age you have found her. So what's the evidence? No delivery decision should be based on the amount or change of proteinuria because we know it is not a single value that can reflect on the actual amount of proteins being excreted. So we don't need to make our decisions based on this at all. Previously, we used to base it on uric acid. Even levels of uric acid, we don't have to make a decision of delivering the patient based on uric acid levels alone. And she can very well deliver vaginally, she can very well deliver normally. Preeclampsia is not an indication of cesarean section. I know we are all blamed for doing a lot of cesarean sections. Our cesarean section rate, most common places are 50 to sometimes even 55%. We don't have to be doing it if we have good monitoring facilities. So this is my last slide. I always feel that we have come to an era where documentation, medico-legal things are just ascending. The black coats are waiting to pin the white coats all the time. So very, very important that in patients with preeclampsia, or for that matter, any patient that we are treating, documentation is very important. And we need to take the right amount of consents and we need to take it in the language that the patient understands. We start overlooking some of these factors. So I thought I must put this slide. And it is no longer counseling. Previously, we used to use the word counseling because counseling is where I keep talking and the patient is going to be listening. It's a two-way communication. So counseling is replaced by the term effective two-way communication. So where obstetrics comes unexpected, unanticipated, and always throwing surprises, and we are always like walking on a trapeze, so balancing two lives at the same time. Preeclampsia is one of the conditions where if we diagnose it earlier, if we evaluate it the right way and if we terminate it at the right time, I'm sure we are going to have good mothers and good babies all the time. Thank you.
One thing common about all professors I've heard at conferences is very precise, succinct and to the point. I would like to request one more round of applause to Dr. Usha for a wonderful, very clear, no dilly-dally, no unnecessary studies, very clear message about what a non-obstetrician is supposed to know about preeclampsia. Thank you very much for a wonderful talk. Any questions from the audience?
Very wonderful talk, Dr. Usha. Long time I had a talk on something to do with pregnancy. About nearly 25 years, I would say. Just one quick question. What percentage of these patients, once you deliver, go on to develop post-pregnancy hypertension? And if so, what is the choice of drug in these patients?
Postpartum hypertension normally lasts not longer than 14 days after delivery. We can still call them as postpartum preeclampsia. Ideally up to 48 hours, upper limit is 14 days. Now maybe around 10%, 5 to 10% will continue to have high blood pressure, but we don't stamp them as hypertension till about 3 months after delivery. 6 weeks is the uppermost time that they come for a checkup. But if they happen to have high blood pressure 3 months after delivery, then we know that she's actually a chronic hypertensive. The drug of choice, we usually give amlodipine or we can give nifedipine. Soon after delivery, we switch. Can continue labetalol for about 2 to 3 weeks till such time that she's there. But after that, the physicians invariably change the antihypertensives.
One definite message, what we nephrologists see, a point not to be forgotten is, if you have a woman who has had a preeclampsia or eclampsia, don't just let them go. There is a very significant increase in later life incidence of hypertension, diabetes, various cardiovascular events, and there are patients who have had underlying chronic kidney disease which just manifests only during pregnancy and it's forgotten after delivery. After 2-3 years, they develop severe hypertension, renal failure, and they present to us. What happens is the hypertension is forgotten after delivery. So as Dr. Usha pointed out, 6 weeks is a rough period where you expect the blood pressures to normalize. Even if they normalize, don't let them go. At least have an annual checkup. Look for blood sugar, keep checking their blood pressure, look for proteinuria in their later life. There is an increased incidence of various cardiovascular events in their later life. So preeclampsia is not just another pregnancy related disease. There are a lot of implications in later life also.
Actually, the patient under, she has a blood pressure of 150/100, and after puerperium has crossed, she has her blood pressure as previous pregnancy blood pressure is 120/80. After puerperium has crossed, it is at around 130/90. So I would just like to ask the physicians whether you would start her on an antihypertensive because she has not reached her normal BP after puerperium.
Sorry, what the
No, there's a patient who's preeclamptic at term, having a BP of around, say 150/100 or 160/110, and after crossing her puerperal period of 6 weeks, she still has a BP which is elevated, but not her original BP, not the higher BP which she was having during her pregnancy. Like, for example, it's around 130/90. So, would you still start her on an antihypertensive or follow her up? She has not reached her normal BP after puerperal.
Yeah, okay. Usually the cutoff is 6 weeks. If the blood pressure remains elevated more than 140/90 beyond 6 weeks, then you will have to label them as hypertensive. So whether you want to, then you will have to treat them like any other hypertensive in the general population. So mild hypertensive, you want to just put them on salt restriction. Severe hypertensives, don't wait, straight away start them on antihypertensives, like what you would do in a general population. So the maximum waiting, appropriate waiting period for them to resolve would be 6 weeks. So any blood pressure which remains elevated, you will have to label them as an hypertensive like you would do in a general population. So I think Jayshankar.
Antenatal steroids, I think we have switched over to dexamethasone. No, I'm still continuing the betamethasone.
Guidelines long back. For several years, it's been only betamethasone. Very clearly says all studies have proved betamethasone.
Yeah, but the betamethasone acetate, we do not get it in India. Betamethasone phosphate is available.
We give betamethasone only, and it's been proved that betamethasone is the ideal corticosteroid of choice.
What is the role of the recent biomarkers? Do you think, the pathogenesis revolves around soluble FMS tyrosine kinase? There are a lot of angiogenic factors whose levels are supposed to be elevated, and a lot of talk about these levels being can be brought into routine use. Do you think they have a role to predict if you have an elevated level as early as a first trimester? Some studies show that they may predict onset of pre-eclampsia after 20 weeks. Do you think it is promising or may not hold water?
We know that those lot of markers are being studied. One of the ones that are now currently for several years being used as a mild predictive possible prediction is doing a Doppler of the uterine artery around 14 to 16 weeks. And they find that if you find a notching, it may predict preeclampsia. Other than that, there is nothing that is really predicting preeclampsia. Currently, studies are going on. It is promising because maybe in future we will find some markers which may be available to predict. As of date, other than the notching that we find in the uterine artery Doppler, around 14 to 16 weeks, we don't have anything that really predicts. All this calcium, vitamin E, so many things have been used. Nothing has been proven to either predict or prevent.
So uterine artery Doppler in the second trimester, third trimester, is it useful to find out the
In the early second trimester. It may predict, that's why I use the word may.
Is there any, does it cause any change in the Doppler pattern? As you said, notching in the uterine arteries.
That is initially it may
In the second trimester, the patient comes with the
notching.
notching. No, hypertension.
I didn't get your question.
Second trimester, it's for hypertension. Does the Doppler reveal any changes?
In the third trimester, like uterine artery notching.
Unless otherwise she develops preeclampsia, she may not show any changes.
Will there be any change if she's having hypertension? No.
See, if she has uterine artery notching in early second trimester, she may develop preeclampsia, she may not develop. If she develops preeclampsia, they may have changes in umbilical and middle cerebral artery. If she does not, it may not show any change. She'll end only with the notching in uterine artery.
Up to 16 weeks, it is there. Notching is there because vessel is not.
Yes.
Penetrating.
So they actually extended to even 18 to 20 weeks. Persisting of that. But it's not a very effective predictor of preeclampsia. We don't do it as a routine.
Thank you. We move on to Jayshankar for the next